Welcome to our grand rounds for today, which is an Engel rounds presentation. And our presenter will be Dr. Aileen Aldalur from the Department of Psychiatry. And the title of her presentation is Building a Program of Deaf Mental Health Research at URMC, Current Progress and Future Directions. And I'll say a little more about her in a minute, but I want to give some usual housekeeping announcements. Okay, first, it's very warm in here. Everybody knows this must be like what Grand Rounds is like if you're on the equator, but it's too hot to put on the AC. Now, if you're watching this at home or somewhere else on Zoom, your cameras and microphones are off. They cannot be turned on. Also, if you're on Zoom, please do not send messages or questions in the chat box. That's reserved for the panelists today. We do hope people will have questions and comments about the presentation for the end. And if you do, there's a Q&A box, and please put your questions there. So if you're watching on Zoom, put your questions there. If you're here live, just raise your hand. Raise your hand, wait till at the end though, when there's actual time to have a question. And also, if you have a question and you raise your hand and someone comes running up to you with a microphone, don't start saying your question until you have the microphone, right? So that way everyone, including people on Zoom, can hear you. We know people are excited to speak their questions, but this is how we have to do it. Anyone who starts speaking before they get their microphone will have their speaking privileges permanently revoked from Grand Rounds, or at least for the rest of this year. Okay, now at the end, there will be a chance to do an evaluation of the presentation. Please do it. You'll see a QR code come up. There'll be a link in the chat box, and then tomorrow another email will come around. So please fill that out. All right, now that we got that out of the way. So today's presenter, Dr. Aileen Aldalur. I believe this is her first Engel Rounds presentation here, and I'm happy she was willing to do one. She received her doctoral degree from Gallaudet University, and then actually did the rest of her training here at the University of Rochester as an intern and fellow, and is now a senior instructor in psychiatry. And she's also the director of research for the Deaf Wellness Clinic, which is a really innovative program that's part of our clinical operations. And all right, so without any further ado, I'm going to introduce her to talk about the research that she's doing now.
Hello, everyone. Good afternoon. My name is Aileen. I work as a clinical psychologist myself here at the Deaf Wellness Center. I provide clinical services for couples therapy, one-on-one, and with our deaf families, but I also am working to establish a deaf mental health research program here. So today, I would like to share my progress in establishing this program and what I hope to see in the future down the line. Before we begin, of course, I have no conflicts of interest to report. So I'd like to provide some context for some of you who may not know what the history of the deaf mental health research field looks like and how the field was established. I'm going to talk about some assumptions, beliefs, and some standard expectations for the field and how this has led to the gaps of research. And these gaps, I'm going to further explain the differences that we experience here in the deaf community compared to the hearing community. My goal in the research department here is to continue to fill those gaps and to see the progress of our field move forward. Most people, when they hear the word deaf, automatically consider it as a disability. But for many deaf people and the community, we consider it a unique culture that has its own language, American Sign Language, cultural traditions, norms. Everyone has experience from deaf residential schools to their upbringing and deaf art. So this here on the left of the slide is a deaf artist, Nancy Rourke. So I'm sure some of you here may know, and you've seen and experienced deaf culture before. Maybe you know a little bit of basic ASL. And that may be because you live in the largest per capita area of a deaf community in the United States. And of course, there's a lot of different TV shows that now are featuring deaf characters and actors. You're seeing interpreters on screens more often at different events. So here are some examples as well. Queer Eye is one of the most recent episodes that we've seen. Switched at Birth was actually started in 2011 with a deaf character. We have in Echo, we have Aliqua that's been here. And then we have Layla here that's actually interpreting on Barbie for HBO. So growing up, a lot of deaf people didn't have this experience. And I'd like to say I'm not that old, but growing up, I did not have these type of role models in the media myself. So this is very new for our field to see deaf people being very prevalent in the community and in media. And over time, deaf people have been using sign language for community engagement, education, and teaching, but society has not recognized ASL as a language and not an official sign language until very later on. Sign language itself was not recognized as a full language until the 1960s. So before that, people thought that sign language was just a gestural system, that it was pantomime, very simple gestures and miming. So they think that deaf people that can't speak, that means that they have no language because the language they use is very basic. It's not considered to have very critical thinking. So automatically people are thinking that people are less than because of the language that they use. In the 1880s, there's a huge deaf conference. This is a very pivotal moment in our history and within our community that automatically you all should know what I'm talking about is the Milan Conference. So that refers to a huge event that really threatened our culture and our community and our language. So educators who were teaching deaf children all were together at the Milan Conference, and they talked about what the best and most effective ways to teaching deaf children were. So at the time, people were using American Sign Language. In Europe, actually, they're using the oral method, so using spoken language. So everyone came together because there's a debate on the best way to teach. And of course, everyone that was there was hearing, but they're talking about the most effective way to teach deaf children. And it was by teaching them spoken language so that they could hear. And they didn't see ASL and sign language as an equivalent language because they wanted hearing people to be able to, they wanted deaf children to be able to function as hearing people in the hearing community. So this is pivotal because deaf children that were born most likely are born to hearing families, and hearing families don't know sign language for the most part. They're not familiar with deaf culture. A few deaf children are born into deaf families and can assimilate into that culture easily. But very often, deaf children born to hearing families were learning sign language at deaf residential programs and schools and picking up culture and language from their peers. But post the Milan Conference, deaf children were told that they could not sign in these areas anymore. So that led to a very abrupt lack of education and exposure to sign language and that socialization. So without that language, of course, these children are going to be set up to fail because they can't hear. And now they're being set up to speak a spoken language without having a sign language there. So that just continues for people to think that deaf people can't do anything because society has told them that they need to continue to speak and look like hearing people to function in the hearing community and in society. So that is the foundation for autism. Autism is discrimination against deaf people. Autism is the thought that people who can hear, speak, or act like a hearing person, they are considered superior compared to deaf people who use sign language and communicate in that way. So autism is what people are still experiencing and navigating in our society today based on all these pivotal moments in our history. So all of this means that in the mental health field, deaf culture, talking about a lens on language and language acquisition, there's a huge gap in our field because deaf people were not considered to be a cultural group in a community until much later on. So early research in deaf mental health focused on this, on sensory deprivation. So researchers were thrilled. They're like, wow, this person cannot hear. How does this have an impact on their intellectual abilities and their emotional control? So a lot of these experiences that these hearing people were working with the deaf patients, and they were not fluent in sign language and deaf culture. So of course, these children were set up to fail. So intellectual testing was very widespread at the time, which was very novel. And they thought, let's test what deaf children and deaf participants look like. But society already had established that deaf people were less than and inferior to the rest of the community. So Aristotle, famous philosopher, said, so you can't speak or you can't hear, therefore your communication and your intellectual ability is similar to animals. So, and then this is just further referred to in our history. So hearing people thought, okay, let's give a hearing test to these deaf children and these deaf participants. And they further referred to these tests in English, but there was no established test for children in sign language that was made for them and fit to their language. At that time, deaf people did not have access to anything. They didn't have access in their home environment because no one used sign language. Then in the deaf residential spaces, they weren't allowed to use sign language. A lot of people didn't know how to problem solve at the time just because they didn't have access to a community of language and everything because it had been taken away in society as a whole. So now that leaves people testing deaf children, but they're not screening and figuring out what caused some deafness. So it could be genetic testing. Maybe a mother while she was pregnant, she got sick, and this causes some comorbidities so for here, they consider that deaf people are always less than because they're not considering what is causing the deafness, where it could be just deafness plus other things contributing to it. So this is what is encompassed in the intelligence testing, is the invalid testing and the improper testing methods. Researchers were also very interested in personality testing. How does losing your hearing impact your personality? Again, these were improper test methods because it was written by hearing people for hearing people, given to deaf participants, and then they automatically referred to this as these people just being less than. With personality testing, if you have a hearing loss, that can impact how you respond to your questions. Like, for example, do you hear things that are not there? Okay. Someone with hearing loss might think of, oh, you know what? I do have tinnitus. So I do hear a ringing. So yeah, I actually do hear things that aren't there, but maybe I don't know what I'm hearing or not hearing. So would you often be concerned of, other people talking about you? Well, yeah, often. Yeah, because I know that in previous context, what deaf people were living through, they were oppressed, they're experiencing autism. People were having their hands restrained to make sure that they were not signing at the time. So of course, I'm concerned about hearing people talking about me and what people may be thinking of me. So these are just normal things that deaf people were navigating in their everyday lives. So now how this compares to the hearing people and their peers is that deaf participants seemed like they had very different personality traits, but it's based on different cultural distress that they have experienced. Now, clinical treatment. So some research and clinicians have noticed, deaf people do need unique and specialized treatment therapies. We can't use just what's been normed for the hearing community. So in the 1950s, we had some of our first deaf programs, and they provide clinical treatment for people who had severe psychopathologies. So they were having treatment done, but also research done on that at the same time. So the research concluded that all deaf people in the deaf community are experiencing these things, but they are only testing on a very small sample of people that were having severe psychopathologies at the time. And then here are the conclusions of that. So big milestones that actually started to impact our field's trajectory. So at first, it's probably one of the biggest and most important one is that sign language was officially recognized in 1965 as an official language. William Stokey, who's actually part of the community and interacted every day with deaf people, was able to note that sign language had its own grammar and syntax and was considered to have all the same nuances of a language. So with that, what we thought previously that sign language was just a very pantomime system, maybe we need to realize that all of our testing in the past that we've referred to deaf people in this language this way has actually not been correct. So now we have to consider about how we're doing intelligence testing and personality testing on these deaf communities is different based on now that we consider ASL being official language. The second biggest milestone is the Section 504 of the Rehabilitation Act. So this required that people needed to provide access services to deaf people, and they need to increase the accessibility for deaf people in treatment centers. So in 1990, there was the American Disabilities Act, and that applied to deaf people in higher education. So meaning that deaf people now could pursue further degrees and they could be part of the conversation about deaf mental health. But since they weren't provided these different accessibility options previously, they were really shut out of the field. And in 1975, there was the Spartanburg Conference, which talked about how to train people and what is considered in training for people working with deaf clients. So they did a survey of deaf clinicians that were working with deaf people and figuring out what is your fluency in sign language? What's your experience with the deaf community? And no one at that conference had experience working at that time. So at this conference, people were able to make a list of, what competencies should be required to work with deaf people and what training should we be providing. And of course, it was a wish list at the time, but it was a great start and a very pivotal moment in our field. So after that conference, that's where we're seeing a lot of different graduate training programs being established that are specializing working with deaf clients. So I graduated from Gallaudet University in DC, and that is a clinical program working specifically on treating deaf and hard of hearing patients. We talked a lot about research methods and such there as well. And there's a lot of other programs available, but Gallaudet is one of the most well-known programs for that in the United States. Here at the Deaf Wellness Center, we have training here too. So we have interns every year that come in and we train people on how to provide services to the deaf and hard of hearing community. Another big shift in our field is that prior research conclusions always concluded that, okay, if there's a health inequity, they say it's because that person's deaf. It's not any other factor of their life. But now we're starting to realize that there's so many other factors in society that could be causing this. Everything from language access to parents interacting with their children, to socialization opportunities, education, discrimination, and even access to health information. That's all been now considered when you're treating a deaf person.
So over this time, we have been able to gather a lot of data, and my current research focuses on this, what you see. So now as we see deaf individuals engaging in a higher education, we are seeing a growing number of deaf clinicians who can provide direct services to the deaf community in their natural language of sign language. We also have programs and policies recognizing special needs and services. So if a provider does not know sign language, they are considered to have to provide reasonable accommodations for deaf patients. And so that is having a factor in these patients as well getting access. Another cool establishment that has come on recently is a new program that we have established. And we've seen patterns of 10 to 15 years of what has been going on lead to these mental health programs. So of course here we have the Deaf Wellness Center, and correct me if I'm wrong, but Deaf Wellness Center might be one of the first that was established for the proper treatment of deaf individuals in our community. There are a few other programs out there as well. Deaf Counseling Center. During my undergraduate studies in 2011, I came in wanting therapy, and I was looking for resources, and I could only find this one option. Back at the time, there was a different name for this center, but it was the only option for me. And at that time, it was only available in the Washington, D.C. area. Of course, now we have more virtual opportunities for deaf-led therapy. Now we have national deaf therapy. My therapist, this new therapy that has been established is virtual and in person, and is rather new to the community now. And then now we have a deaf-led, officially deaf-led program called My Deaf Therapy. And these are the options out there, but they're few and far between compared to what hearing people are able to access. So we have deaf clinical services, and they've been improving over the years. We've seen this progress. But as far as deaf mental health research is still lacking. As of right now, there are few deaf researchers that are able to access grants and be able to perform the research needed for this field. Deaf mental health research right now, I am aware of only 3 people that are doing that work globally: myself, one hearing individual, and another deaf individual. That is it. So the numbers are few and far between who is doing this research out there. And being able to set up mental health services needs to be catered to the deaf community in a different way. We have the Deaf Yes program, and one of my mentors is involved with this. And they're doing clinical treatment research as well. We also have 2 labs at Gallaudet University that were recently established only a few years ago. So a lot of good research being done in the field at Gallaudet University as well. And then there's also a visual language access and acquisition lab that Dr. Wyatt Hall is working on here at University of Rochester. He is a clinical psychiatrist and doing a lot of research in this field as well. So with this new research that is being implemented, we are able to gather and learn some things about deaf mental health research. And mainly we are realizing that there is health disparities in this field. So oftentimes deaf people are prone to experience more anxiety, depression, suicidal attempts, ideations, traumas, alcohol, addictions, etc. And we have to consider why we are seeing this and what is unique to the deaf experience that could be causing these mental health inequities and disparities happening. And so a lot of research is being done now related to the childhood experience, the adverse childhood experiences. What do they experience from lack of communication with their family, lack of access in the world, and how does that relate to their mental health later in life? So a lot of new work that we are doing is related to that. As you can see here, we are making progress. Now, yes, there is progress, but at the same time, we're recognizing there are significant gaps left in the field. We don't really have a lot of significant research related to percentages for deaf mental health disorders, related to deaf people, deaf culturally, how is that affecting it? We do realize that deaf people are more prone to anxiety because of their deafness, but we are not realizing at a percentage rate. We have small focus studies on this that's taking from a small sample size, and we're not able to always differentiate who identifies as culturally deaf versus maybe late deafened or have a hearing loss but not culturally deaf. And so from this information that we gather, oftentimes it's administered by hearing people. We'll be able to pull from census data, but again, that is going to be biased. The one administration, the Drug Abuse Administration and Mental Health Services Administration, surveyed globally and collected from population of hearing people, but there was no questions that related to who identifies as deaf, who uses sign language, who is culturally deaf. And so unfortunately, we're not able to analyze that data because we don't know who identifies that way. So, and we do not have data on how many deaf people are actually receiving mental health services. Another reason that we don't know this information is because we don't have many clinical assessments provided in American Sign Language. A lot of work is being done to translate these into sign language, but many of them are not ready to use yet. So having an assessment in sign language and surveying that out to the deaf community is limited. Those who might not be fluent in English might not be able to be a part of that survey, and so we are disregarding a large number of the population. We also realize there's a lot of information related to deaf culture, and those factor into the mental health status of a deaf individual. We'll see different groups and see there's projective factors that affect their identity, and we don't have a lot of documented information on that as well. The social cultural influences. So given all of this, we don't have the outcome data for mental health treatment. We are servicing these patients and we might be seeing progress, but we are not able to formally document that because we do not have these all set in place. So if we don't have this outcome data, that means that we don't have evidence-based interventions for these deaf individuals. We don't know what treatment will actually be effective for these deaf individuals. We just have to try by trial and error. If we notice a deaf patient has depression symptoms and we place them in services that are accommodating for hearing people, they might not always be accommodating for the deaf patient and what their needs are. And so we don't take that into consideration yet in the field. So our field, how it's been changing over the years and what it leads to now. This is my beautiful team, as you can see here, the Deaf Wellness Center. Deaf Wellness Center was set up in the 90s by Bob Pollard and Eric Kane. And the goal was to set up clinical services, education, and research in the deaf field. So we've been providing clinical services for the deaf community since that time. I'm sure you've seen clinicians here in the hospital working with deaf patients. We are present at deaf community events. We host trainings. We have interns, part of our program. In the research field, Bob was a researcher at the time, and he was doing a lot related with dialectal behavior therapy, DBT, and how to adapt materials to provide services to accommodate the deaf patients here at the hospital. And Bob also did a lot of research related to the interpreting process in mental health. What is the best model to use for providing interpreting services in the mental health field? Now, after Bob retired, we have not been able to replace that research here. So when I came here for my PhD internship, I realized there was a lot of gap in this research and I wanted to take it on. Fortunately, I was able to do my post-fellowship here, and I engaged in a lot of the research, and I brought what I had previously done in my research to the Deaf Wellness Center, and that's what led us here today. So I'd like to show you a little bit of my work and what I'm doing in the field to help fill in those gaps. A lot of my early work was related to socio-cultural factors and how that affects the deaf mental health experience. In graduate school, I looked a lot on acculturation and the deaf acculturation experience, meaning a person that has two different cultures and experiencing multiple oppressions, trying to access language and navigating that path between the two cultures through their childhood. And reason being, I decided to research that is because I had a personal experience with it. Growing up as a deaf individual in a hearing world, I was told to assimilate with my hearing peers and hide my deaf accent and follow the hearing culture norm and beliefs. I didn't have sign language until I was 19 years old. And when I finally was exposed to the language and the culture, I felt part of it. But at the same time, I still felt as an outsider in the deaf community because I was not fluent in sign language at the time. I did not know the history. I did not fit in with the culture at the time. And so I was experiencing this oppression from both sides. And I realized that there was not much research for that type of situation of acculturation. So I decided to measure that experience of that oppression from both sides and see how that would apply to the deaf mental health experience. And yes, oppression can lead to depression, anxiety, several different disorders that affect an individual, and realizing that those cultural factors also play a pivotal role in the deaf patient experience as well. In the field of psychology, we talk about the cultural concept of distress and having different cultural groups and their experience having to explain mental health disorder problems, or maybe what might be unique to that culture. Whereas one culture might have a certain type of experience that another culture might not. So working with the deaf population, oftentimes our patients come to our office and they want to talk about the deaf experience. And a lot of commonalities are out there of the deaf experience, but we don't have them documented. As a deaf individual myself, I can relate to my deaf patients because I have those experiences. But again, we don't have these specific experiences documented for the greater good. So a deaf person might read these up above and relate to them, but a typical hearing person might not have ever heard of the dinner table syndrome, for example. So oftentimes at the dinner table, if there's one deaf individual with their hearing family, the family's having a discussion, speaking in English and talking about how the day is going and all of this incidental learning that a deaf person does not have that access to, and that information sitting at the dinner table. And this happening over a course of time can have a significant impact on them later in life, not getting that incidental information happening at the dinner table. So having this type of information documented can help us be able to identify the factors that affect deaf people mental health with this. So using the American Psychological Association interviews we conducted with deaf patients, being able to document these different experiences that is unique to the deaf community. So other gaps we have, of course, evidence-based interventions. During my postdoc, I got a diversity supplement from the NIAAA and able to provide my research, and realizing one of the biggest barriers or preventions for deaf people accessing mental health services, because those who do have deaf mental health just do not seek the treatment that they need. And we're seeing this even more in the deaf field. During this survey as well, it was documented that 73% screened positive for one or more disorders. And of that 73%, only 28% were actually engaged in treatment. And comparing that to numbers of hearing individuals, there was quite a disparity. Fortunately for me and my mentor, we've already been able to develop treatment to work with individuals for this and providing the treatment that they need. And so we have our cognitive behavioral therapy for treatment seeking individuals that we are using. And with that, I decided to adapt and match the needs of my deaf patients. So I'm able to learn from that and follow the structure with the 8-step process. And I will just quickly go through what that model is and what the 8-step process is. So this treatment intervention is based on those who might have mental health issues and need to be able to seek treatment, but trying to identify what the barriers are for them to be able to seek that treatment and what they do to problem solve in order to seek that treatment. And so specifically looking at deaf individuals and what are those barriers that they might be experiencing. So in order to do that, we interviewed a handful of deaf patients to collect that information. Some of the results we gathered is when we asked why not engage in treatment, a deaf person often mentioned not wanting to engage with a hearing clinician and have that lack of communication access stress them out, and in turn would less likely want to pursue more treatment. Oftentimes, they also express that it would not benefit them and the cost would be too high compared to the benefits of seeking treatment. Also talking about community beliefs. Within the deaf community, mental health treatment is not often recommended. The healthcare system as a whole is not as trusted by the deaf community as well, so this leads to less wanting to seek treatment in general. At the same time, the deaf community is very small, and so seeking treatment can cause chances of their information getting out there in the community, and that's also something that deters deaf people from wanting to seek treatment. And finally, deaf people in general experience significant barriers compared to their hearing peers. So they might want treatment and find out that there's no signing clinicians or no one that's culturally aware of deaf culture providing clinical treatment. Or if they do find someone that is aware of some of it, they might get there and find out that they're not willing to provide accommodations and interpreter services for the appointment. And unfortunately, in small communities, if there is deaf or signing clinicians, if it is a small community, the patients might already know those clinicians personally, not want to use them for services. Or whereas if they are their patient, then out in deaf community events, they might run into one another on a personal level and not want to have that type of interaction.
So using that information that we were able to gather in those measures, I went ahead and I ran focus groups with deaf community members and with clinicians that work with deaf patients. And I was able to show them what the original CBT-TS looked like. And I said, tell me what needs to be adapted for this to better work with this community. So here's what the structure of it looked like at first. So starting with one session, before that session, we were actually able to ask them what their beliefs were about treatment and what barriers they face. During my session, I was able to talk and problem solve and try to connect them to engage in therapy and services. So what was changed over time is that interview data, I was able to actually put that onto a measure. That way we could analyze deaf beliefs towards treatment seeking or what barriers they face. And then I was able to add different deaf culture information and different beliefs that the community have as well throughout the survey. And this is to help people find treatment and treatment needs. So very often people face these barriers. They don't know what options are available. But now with this, I was able to actually add more deaf specific resources as well. And I added a second session because since deaf people face more barriers, I added more additional supplemental support throughout that process and to provide resources. So with that, I had to extend my session times. So as I adapted that measure study, I was able to apply to the National Center for Advancing Translational Sciences. And with that award, I was able to go ahead and test my treatment services now. So with this, I was able to recruit and train a team, which you can see my team here on the screen. Everyone is deaf and everyone is fluent in American Sign Language. So we ran the first deaf mental health clinical trial here at URMC. Previous to that, there had been none. And it was really successful, I'd say. So our study coordinator was Sean Collin and was awarded for his work as well and for our participants engagement award. So how did we test this? So we did an open pilot trial. So our goal was to have 30 people with mental health issues that had not been engaged into treatment. So no one had received treatment in this group. So we were able to screen them. And then we went ahead and analyzed what their beliefs were, what barriers they faced about treatment seeking. And then we had 2 intervention sessions. And a month after that, we were able to do an analysis again about their beliefs and what barriers they faced. And then we asked them, did you start the process for treatment? Did you seek treatment? And we asked them, how do you like this intervention? Are you satisfied with the services you received? And we were able to really work with this group that way. So we actually just finished data collection recently. We've tentatively started some of our analysis, but this is what we found so far. So we had 3 aims. The first is that we wanted to know, did deaf people like it? Did they feel satisfied with treatment and their experience with it? And can we run a clinical trial here with deaf people again? The answer is yes, unanimously to both. Yes, we can. We can run a deaf clinical trial here at U of R. We had a goal of 30 people. We got 33. And of course, we were approved for that. But we were able to get 33 people for this trial. We thought it would be a 1 year for us to actually have all these participants signed up, but it was significantly less than that. And in our study, from treatment to follow-up, it was 94 retention, or we had a 94% of retention in our study. And at the end, for our client satisfaction questionnaire, I think we had it an average from 1 to 4. 4 being that they loved it. Our average response was 3.74. So it said that people were excited about the services that they had, that they would be willing to refer their friends to our services, and that they would be interested in continuing with interventions here in our clinical trial. My second aim was to see if the intervention had worked. Do people actually look for treatment afterwards and after engaging with us? So of the 33 people that got this intervention, 26 actually contacted for treatment. 57 of them actually contacted and scheduled for it. 26 of them contacted treatment. 4.3 of them scheduled it, and 26 attended at least 1 session. So someone of these groups, that people at least had a scheduled appointment at some point down the line because of this. And our third aim here that we haven't started yet is that with the feedback that we've able to collect from all of our participants, we figured out, can we actually improve this intervention, and what feedback do we need to modify our treatment for future studies? And my last field of work that we are working on here in our community at U of R is deaf health equity, especially in the healthcare system. So maybe some of you know this already, but we were able to set up the Universal Depression Screening Initiative. So meaning that patients that are not in mental health services or engaging in the department, but just anyone that's going to their PCP or a specialty clinic, they will be screened for depression there. So that's helping us to capture people early on to see if they have any early risks and get them into services. So when we accessed that data from 2015 to 2018, all patients that had already done that, and everyone has already done that depression screening, we were able to identify how many of them were deaf. And on e-record, if it says that their primary language is ASL, that's how we were able to identify them in this. So we were able to find 527 ASL patients in this system out of around 2,000 deaf patients in the whole e-record system that we have here. So when we saw the deaf patients, we did see that they had an average level of depression scores, and they're more likely to have a depression diagnosis. So that showed that this is actually really, really critical that we're doing these early screenings to capture who needs these services and getting them in earlier. But the problem people faced is that this screening is not available in ASL. It's not accessible for people that use sign language. It's translated in English and Spanish, but we don't have this available in ASL. Like Promise and the PHQ-9, out of the 2 of them, these are not available in ASL. So our goal right now is that we're trying to collaborate with Gallaudet University in Washington, D.C. They have a really cool translation center there that they're doing a lot of good work translating different health measures. And we're working with them to translate several health measures, including the suicide risk and different deaf culture measures that we can use in Deaf Wellness Center with our patients. So we're hoping that with these translations, we can go ahead and establish that here at U of R with the pilot testing and test the efficiency of that, and hopefully improve deaf health equity here at U of R. So future directions. With the progress that we've made in the field and recently here in Deaf Wellness Center, I did recently apply for my K-23 Career Development Award. So hopefully with this, we'll be able to do more testing for CBT-ETS and working with these communities to improve treatment engagement and reduce the risk of suicidal ideation, especially amongst people in the community. So we're hoping that in Deaf Wellness Center, we can have more outcomes-based research because we have incredible deaf clinicians that are providing exceptional care to our patients, but we want to make sure that we have the outcome measures documented that we can reinforce that. So we want to keep working with our DBT adaptations and continuing training for trauma-based interventions so that we can set up a model to test it here at U of R. We really would love to expand our training opportunities for people that would like to learn here with Deaf Wellness Center. There's really limited opportunities for people to come, but we want people to be able to come and learn more. That way we can increase our pool of deaf research. And I would love long-term goal to establish a translation center here so that we can learn what different methods and approaches are working best and then set that up here. So anyone in different clinics that has different health materials or any measures that you want to provide to deaf patients, you could share that with the translation center and they could make sure that that's accessible and equitable for those patients and for you to use that further on in your work. And above here, all of my acknowledgements. I have a lot of people to acknowledge for my progress in my career. So thank you. And that's everything. So I'm happy to take any questions that we may have. Thank you.
Okay, do we have any questions?
Hello. Thank you for, I'm here, yeah. Thank you for that great presentation. I had a question about kind of considering kind of the whole staffing team within that model. You know, you talked a lot about kind of the coordination between ASL fluent clinicians working with the patients. I guess I'm thinking when you're talking about satisfaction and outcomes, were there any considerations for, were there any differences, for example, in regards to like sort of the broader treatment team, if perhaps the medication provider isn't fluent in ASL or if we were using peer services? I guess is that like sort of a next level or approach to think about the broadness of the clinical team and how many of those staff members may or may not have fluency in ASL?
Just want to make sure that I'm still on the camera for those on Zoom before I respond. Yes, I would love to make progress in that research and provide it for the whole medical team. Currently, most of our clinicians are deaf or fluent in sign language, working with deaf individuals. And so they have that experience, but our goal is to apply this to clinicians that don't have that experience. So yes, in my interventions, we'd love to have more clinicians available to provide services. And so if we can actually train clinicians that might not have experience with sign language or deaf culture to be able to provide effective treatment, I think that's important to work towards. So yes, I'm hoping in the future we will expand towards that, but thank you for that question.
You had a really impressive recruitment rate, especially ending early. Asking for a friend, do you have any tips on how you were able to pull that off? That's the opposite of what we usually see in a clinical trial.
Yes, I was also impressed with those results and was very unexpected. So we have a handful of methodologies we use for recruitment. One that I think helped for recruitment was using MyChart. And so I think also what was also very helpful is having a team of deaf researchers involved, and we're already involved in the community. So there's a lot of strong networking within the deaf community that we have. So that helped us with recruitment. We have access to different deaf community centers in the area that were able to help me actually send out information on it to recruit. So that was definitely a helpful factor.
We have a question on Zoom. Steve, could you give that to Kim, who'll have the next question? The question on Zoom is, do you have any plans for extending your work for children and adolescents?
I hope so. As of current, no. I have not been able to start work on children and adolescents, but the Deaf Wellness Center for clinical work, our goal is to expand our pool and include more teens and adolescents in our work. But there are a lot of barriers related to that currently. In my research right now, I'm not considering it, but I do envision down the line being able to do more translation work with deaf children as well and providing access for them in their sign language.
Okay, Kim?
Aileen, you've taught me so much about the challenges in doing research with the deaf population. Can you talk to some of those that you've had to manage?
I think the biggest challenge is reviewing a lot of the history related to deaf oppression and the negative experiences in the healthcare system as a deaf individual. And that includes research as well. Deaf people are afraid of being involved in research. They want to know what is happening, who's on the team, what the results will be a negative impact on them as a deaf individual. And so when I started doing my research, I realized the biggest challenge I was having was developing trust with my those involved in my research. And so even just 20, 25 minutes of sitting down and having that discussion was not enough beforehand gathering my data. So we'd sit down with the individuals and they would ask us a plethora of questions. And so realizing we needed more time ahead of time to build that trust before administering the research was very important. And so I think a biggest challenge was just building that trust with the individuals involved. And also, there's not many measurements available in sign language. So I'd want to do an assessment with my patients, and I'd love to be able to just set up a survey and hand it out there and have individuals fill it out, but realizing it's not accessible in sign language yet. And so that was also a big barrier we experienced. So the type of assessments we wanted to provide, we also had to do it on Zoom. And so oftentimes we weren't sure what their language preferences were and how to administer those questions. If we had 50 to 60 questions and I'd have to sign them to each individual, was very time consuming. So that was another challenge we experienced. So overall, yes, our research was successful because we were able to do it on a small sample, but it was very time consuming individually. And also we were able to do this nationally. And so I had to seek specific expectations for doing it nationally as well, and realizing that the community in Rochester is very small. So having to consider the deaf community at large throughout the country is also important for this research.
Okay, we have another question that's come in on Zoom. And this question is, have you faced specific barriers to building your research efforts within UR and URMC that can be overcome for the benefit of other deaf researchers in the future?
So specific barriers here, research related, I will say my experience, I've been very fortunate. I've had a great team, great support. I would say the only specific challenge I've faced is access to sign language interpreters and having issues with getting interpreter services if interpreters are not available, because unfortunately there's no deaf mentors here available for me. So I would always have to request interpreters in order to meet with other individuals. So I guess I would say the lack of enough people knowing sign language or having experience with that in the community is one challenge. and also those outside of the University of Rochester community not having exposure to the language or culture. So honestly, if I don't have an interpreter available here, or they get an interpreter from outside the community that doesn't know the information, those are also both challenges. So I think that's true to a deaf individual anywhere, not just at University of Rochester. So I think not having a mentor that knows sign language, that can be a barrier as well. But overall, I've had a great experience.
All right, well, we have time for more questions. So here's another one. Can you recommend any educational resources and ways to continue enhancing our knowledge about deaf culture that we can access ourselves and offer to trainees to continue combating bias and inequities for deaf and hard of hearing individuals in clinical care in the here and now?
I think it's easy to find a lot of materials out there now, but related to mental health, maybe not as much, but I can think of some within Bob Pollard's research. So he did a lot related to deaf mental health. So you can also reach out to the Deaf Wellness Center here, and we have training materials that we can provide as well, presentations, et cetera. Another thing that was recently released by the University of Massachusetts, Melinda Anderson, research related to providing mental health care to deaf people. There was actually a really great movie that was just made about the deaf wellness experience. And so I would recommend looking into that, University of Massachusetts, and trying to get access to that movie.
Okay, well, I think we have time for one more question, which I just happen to have myself. And that is, what would you recommend for someone with psychotic symptoms who's deaf here, who comes to treatment at the university?
So my recommendation specifically, I think we actually do see a lot of that at the Deaf Wellness Center. So I'm pretty confident that we would be able to undertake that, providing certain assessments. Now, if a hearing person is administering the assessments for a psychotic individual, the recommendation would be to have a deaf interpreter, an interpreter who's also deaf, because of the language nuances. And so it is harder to differentiate what is psychosis and what could also be language deprivation related, or inaccess to language in their childhood. So being able to have a deaf person who's specialized in that field to help assess with those kind of things, if they're able to differentiate those. So I think having a deaf person in the room is very important for a situation like that, or a deaf clinician, somebody that's experienced with that specifically.
Okay, so we're just about out of time. I want to thank Aileen for an excellent presentation, and our two hardworking interpreters today as well. And thank you all for coming, and we'll see you next time.